And your goal is merely to hold your eyes still and steady, straight ahead as you have it now. Even if the light seems to move, you just want to do your best not to move your eyes around, but to stay pretty much where you are unless I ask you to change your position. You'll see light and motion and color, nothing distinct or disturbing. We've begun. You might notice a slight sting for a moment. If you do, it'll just last a moment. It's a little extra anesthetic for your comfort. The light might come and go or change color. That's normal. I've made openings that seal themselves in virtually every case. Pretty colors as we use this gel to coat the delicate surface inside and out. Keep it smooth and comfortable throughout the case. Look at the light, please. Kaleidoscopic effect here. Visual highlight of the surgery. Last of the annoying eye drops. And look at the light again and hold steady there as best you can the next minute or two. That would be particularly helpful as I open the front bag or capsule of the cataract. It's a tissue 100 times finer than saran wrap. My goal is to make a nice continuous circular opening, which will contain the implant that we'll place inside the bag once we get the cloudy stuff out. Just stand your ground, hold steady, don't try to follow anything. The more you can just stay in the direction of the light, the less the light will seem to move. I've achieved my goal with perfection. You'll notice that the light gets dimmer or less distinct as I use fluid to separate the onion-like layers of the cataract, releasing its attachments to the bag for safe removal. You'll be hearing the interesting noises of the ultrasound machine in a moment, the instrument that lets me remove the cataract through this small opening. A little cool feeling goes with, some people notice. Using sound waves moving at 40,000 times a second to break up the harder center part of the lens we call the nucleus into sections that we'll be able to suck out through this little tube. Quadrant. Everything's going our way. The hard center part of the lens, the nucleus is out. We have softer cortical material left to remove. You're comfortable enough, aren't you? Mm-hmm. Excellent. Switching for a more delicate instrument to empty the bag entirely. Cool feeling again if you noticed it before. We're done with ultrasound. We're using vacuum alone for the sticky outer layer called cortex. Stripping that away so we have a perfect clean place to put your implant. One. Cataracts out, a little housekeeping left to go as well as the implant. You're on the home stretch. Polishing some last little cells off the back bag so it's crystal clear.
WF 18.5.
WF 18.5.
Thank you.
Look at the light, please. Preparing to place the implant. Look towards the light. Kind of fight to look towards the light. That's it. Keep doing that if you can. A moment. Things will brighten up as the lens goes inside. It was folded into a little tube. So if you go through this small opening, and springy arms will open to keep it centered and secure within the bag. A little housekeeping and you'll be out of here. Cool feeling for the last time perhaps. Making certain we're watertight without a stitch by being sure there's no gel between the lips of the incision. Finishing with a little antibiotic to foil any germs that could have escaped all that cleaning. And adjusting the pressure to normal. You're a great patient. Things have gone without a hitch. You may stoop, lift, and bend and use your eyes. Just don't rub it or get anything in there. 40% chance you'll see just great today. 90% chance it'll be clear by tomorrow.
Here's the left eye of a 23-year-old woman with an infranasal cerebrotic melanoma, which an ultrasonography measured 4.5 by 3.9 by 2.0 millimeters. Here we are at the start of the operation, estimating the diameter of the tumor, the scleral opening, the superficial scleral flap, and the conjunctival flap. A fornix-based conjunctival flap is made. Traction sutures are placed in the sclera. Then a partial thickness scleral incision is made radially on either side of the tumor, clearing the tumor by about 4 millimeters. Then radial incisions are made so as to create a limbus-based lamellar scleral flap. The scleral flap is as thick as possible and is made with a Demar scarifier. The flap is extended into cornea. The sclera is speared, then pinched and shaved so as to create an opening without damaging the underlying uvea. The incision is extended around the tumour to create a stepped scleral wound edge. Then the anterior chamber is entered anterior to the tumour. Next, an opening is made in the peripheral iris, and this is extended around the tumour with a slight clearance margin. The iridocyclectomy is performed circumferentially, taking care not to damage the lens and vitreous. The systolic blood pressure is lowered to about 70 millimeters of mercury. And his zonules are brushed away. The scleral flap is unfurled. And sutured. The pupil is reformed by stroking the cornea with an iris suppositor in a peripheral direction. Viscoelastic is injected into the anterior chamber to prevent postoperative hypotony and hemorrhage. The conjunctiva is closed in the usual manner. And subconjunctival injections of antibiotic and steroid are administered. Mediatric drops are also installed. Here's the patient 2 months postoperatively with vision of 20/25 and good pupil, no complications. Histology confirmed the diagnosis of melanoma, and cytogenetics showed a partial deletion of chromosome 3.